Hey everyone, I'm just pulling up the slides. Okay, so I think most of you know me. I'm Nuri Jacoby. Hi everyone. I'm speaking with Dr. Dattner, and we're going to be talking about writing effective narrative evaluations. And I've been reading narrative evaluations as associate clerkship director and now co-clerkship director for a few years, and I've been writing them since I've been faculty. And I recognized how challenging it is to write these, and I've seen that it's a skill that really is not innate and needs to be taught. So this is important for all faculty and residents who are working with medical students. But these tools that we're going to learn about today are helpful for writing letters of recommendation. They're helpful for writing narratives for faculty who are reviewing residents. So this is really useful for a lot of people.
And thanks so much for inviting me. I'm Laura. I'm visiting from pediatrics. I also want to say, I believe it's St. Patrick's Day. Happy St. Patrick's Day. I've been interested in this topic for a long time because I know how hard it is to write an evaluation. And also, as one of the clinical advisory deans, I've been reading our faculty's evaluations as they go into the NISB, or medical student performance evaluations, along with your own Dr. Resnikoff. Actually, we've been doing this job together for many years. And so we've seen how this is an area where our faculty could probably improve. Okay, so we'd like to start by asking you some questions.
All right, so hopefully this works.
This is going to work, don't say that.
So everyone go to, let's see.
Whole EV.
Yeah. wholeev.com. Where did it say?
And then Nuri Jacoby 093, right?
Yes. Thank you. And please let us know how comfortable you are writing narrative evaluations.
So there should be letters. If you're very comfortable, that's A, somewhat comfortable B, somewhat uncomfortable C, and very uncomfortable D. So wholeev.com/Nuri Jacoby, all one word, 093. No,
can you repeat it again? Nuri Jacoby, what? 09?
093, yeah.
Does anyone have it?
wholeev, yeah. Really?
Your question. That's interesting.
Let's see. All right, we'll start with the second question. Have you ever had formal training on how to write a narrative evaluation? Is it working? Right. For some reason, this isn't working. I apologize. Let's see if I can see it on the website.
Nuri, can you hear me?
Yeah.
So make sure you're sharing your whole desktop screen, not just your PowerPoint presentation.
Oh. Okay, that might be the issue. Thank you.
Hope that works. That's been an issue for me in the past.
Yeah,
with POLUV specifically.
yeah, this worked in the past multiple times. Let's see. Okay. Is it working now?
People have put in their things, but
All right, if it doesn't work in a minute, we're going to assume that people haven't had training and that they're not comfortable, because that was the point of this. So yeah, how about a show of hands? Who has had formal training in writing narrative evaluations in the audience? All right, Dr. Merlin. Anyone else? No, I had never had formal training too. That's one of the reasons I wanted to look into this. So let's talk about it.
so we'll start with what is a narrative evaluation, and it's written comments from faculty that assess learner performance and achievement in meeting specific objectives of a course or clerkship. And we all actually have a mandate from the LCME to do this, the Liaison Committee on Medical Education. They tell us that a medical school must ensure that a narrative description of a medical student's performance, including non-cognitive achievement, is included as a component of the assessment in each required course and clerkship of the medical education program whenever teacher-student interaction permits this form of assessment. And this is, for those of you who remember the recent LCME visit, element 9.5. Okay, so there's two types of evaluations in general. There's formative evaluations and summative. Formative evaluations provide feedback to learners about their progress. For example, this could be the feedback you provide after directly observing a student do a neurological exam, or maybe mid-clerkship feedback. And then a summative evaluation measures the achievement of learning goals at the end of a course or clerkship, such as your end of clerkship feedback. And narrative evaluations can, of course, be either, but here we're going to talk about summative evaluations. And we'd like to start with an example, and I'll read it for you. JJ was a pleasure to have on the team. She's a wonderful and caring person. She worked hard throughout the rotation. She'll make a great doctor. So we'd like your feedback on this. How do you feel about this evaluation? How would you feel about it if it was written about you? How would you feel about it if you were trying to evaluate this student after hearing this feedback? And what are the pros and cons of this evaluation as you see it? And
Yeah, Dylan.
I guess if anyone on Zoom wants to raise their hand, we'll try to come to you too.
Not a person, but not actually helping them.
Excellent. So for those of you who couldn't hear Dylan, he said that it was very positive, but didn't provide any constructive criticism and didn't give him an indication about how to change. And Dima says that it's generic.
Yeah. How do we even know? You can't lean from this narrative that whoever wrote it knows who the trainee or the learner is, right? This could be written about anybody. There's not really any specifics that say this is who the learner was. Any other thoughts? Yeah. Yeah.
Amazing. So, and you are? Okay, so Christine could give our talk, but basically she said, this shows that the person is likable, but doesn't tell you anything about their professional competence or how it would be to work on them, to work with them. And we're going to get back to that because she's totally right. Okay. So why are narrative evaluations important? First, they add qualitative information to a quantitative grade. They provide additional individualized and specific information about the learner. They're an opportunity to highlight a learner's strengths. they're likely to carry more weight going forward since now step 1 is pass fail. And also some schools are removing grades and rankings altogether. And lastly, they're included verbatim in the dean's letter, or MISPE, the Medical Student Performance Evaluation. And that brings us to the residency perspective. So what are the residency directors looking for? In 2020, the NRMP did a survey of program directors, like 600 different program directors, not only in neurology, but this was in all fields. And they asked them, what are the most important factors determining who's offered an interview? And we'll talk about these top ones, but we can also just say that since then, USMLE step 1 has gone pass fail, so that's no longer one of these criteria. But you can see up here in the top 4 is the MISPE or dean's letter, and you can see that that is considered more important in the granting of an interview, even than the grade in that clerkship. And then these same residency directors were asked this important question, which is what determines if this candidate is going to be a successful resident? And you can see these top 5, which are, they determine the most important factors are professionalism, the quality of the candidate's patient care, the clinical competency, their ethics, which is professionalism, and their communication skills. So this is like just like what Christine was saying. And I highlighted this because we're actually going to come back to it. But please remember, these are the things that the residency directors have determined to be the most important for them. And that brings us, sorry.
Okay, so I'm going to talk now about some challenges to writing good narrative evaluations. And there's a lot, it's hard. First of all, we're all busy, right? We don't necessarily have time to write long narratives for multiple students 8 times a year. And it takes time to write a good narrative. Faculty are reluctant to include negative or neutral comments. It's very common that all evaluations are really glowing, right, and platitudes. And faculty kind of feel bad to write anything that might be perceived as negative. Residents as well, they also feel bad about that. It can be hard to know what to write. Again, we've never really been taught this. So we kind of go towards personal attributes. They're really pleasant. They're a pleasure to work with. They're going to be a great doctor. And then it's hard to remember, excuse me, all the details of each student. So a lot of times we're writing a narrative 3 weeks after working with a student. And we've worked with 8 students that month. And it's hard to remember what knowledge did they know exactly? What presentation did they give? So it's hard to remember all the specifics. All right, so because of this, there's been national efforts by the American Academy of Medical Colleges to improve narrative evaluations. So in 2016, the AMC published recommendations for revising the medical student performance evaluation, or the MISPE. And so in it, they write, the purpose of the MISPE is not to advocate for the student, but rather to provide an honest and objective summary of the student's personal attributes, experiences, and academic accomplishments based to the greatest degree possible on verifiable information and summative evaluations. Now, this publication didn't specifically talk about narrative evaluations of the MISPE. It just talked about the MISPE. So in 2019, a working group was convened called the Writing Effective Feedback for the MISPE Working Group. And they did a literature review, and they made some recommendations. And what they determined are that narratives are lacking in specificity, transparency, usefulness, and equity. And what they did is they hosted workshops nationally, and they created faculty development modules. They actually published their work in 2022 in MedEd Portal. So Dr. Dattner and I were not aware of the national efforts that were occurring, but we were actually quite pleased to see that a lot of the conclusions and recommendations that we ended up making were the exact same that this working group made as well when they published this at the end of last year. All right, so let's get to what to write. So I think it's really helpful to use a framework when organizing a narrative. Right, so frameworks help educators guide learning and assessments by providing level appropriate expectations for learners as they progress through increasingly higher levels of training. there's a whole number of medical education frameworks. And so we'll talk about 3 of them. The first one I think we're all very familiar with. They're the 6 ACGME competencies. They work really well as a framework for how to write a narrative evaluation. And for those of us who are preceptors, for the medical students, in new innovations, it's actually broken down by the different ACGME competencies. So they provide prompts for what we could talk about. A second framework is PRIME. It's really rhyme plus professionalism, which I'll talk about. And then the third is the narrative evaluation quality instrument, which I'll talk about as well. So here are the 6 ACGME core competencies. So again, you don't need to write about every single core competency when making a narrative, when constructing a narrative evaluation, but think about the ones where you know the most about the student, right? So when we think about practice-based learning and improvement, right? Is the student reviewing their patients? Are they reviewing the literature in regards to their patients? Are they quoting studies when giving presentations, right? That would really be exceptional. When you think about systems-based practice, is the student thinking about all aspects of medical care, right? Are they thinking about cost of medications, cost of healthcare? Are they thinking about interprofessional teams? All right, so I'm going to spend the least amount of time on that one because again, I think we know the ACGME competencies. So let's talk about the PRIME. So the RHYME method was first developed in 1999 to assess internal medicine residents, but it was quickly adapted for medical students. And so in PRIME, each letter stands for one of the skills that medical students should acquire. P was added later on, which was professionalism. So R stands for reporter. So the student should be able to gather accurate history, perform a physical exam, differentiate normal from abnormal findings, effectively communicate when giving a case presentation. I stands for interpreter. So here the student should be able to utilize clinical reasoning to determine pertinent positives and negatives. They should be able to develop a differential diagnosis, prioritize problem lists, and interpret diagnostic tests. M stands for manager. So develop diagnostic and therapeutic plans. And E stands for educator. So engage in self-directed learning, look for evidence in the literature, and teach others, including colleagues and patients. So generally, the way we should think about it is that in the preclinical years, students will learn how to become a reporter and start to learn how to become an interpreter. And then during the clerkship years, they're going to really refine those skills and then learn how to become a manager and educator as well. And then this is lifelong, right? We're all continuing to improve this. We're all becoming better educators as faculty as we continue to progress through our career. Here's the narrative evaluation quality instrument. So I was actually really excited when I saw this. This was developed in 2020 by neurologists at the University of Rochester by Kelly et al. And there's a bunch of neurologists there. And they did this really as a method to improve narrative evaluations. So they developed this instrument. They proved its validity. There's 3 components to it. So the first is performance domains. So there's 8 performance domains they list: overall performance, clinical skills, clinical reasoning skills, preparation for and participation in patient care, fund of knowledge, written and oral skills, taking initiative, and professionalism. So how many of these domains are in the narrative, right? And it doesn't, again, this is like the ACGME competencies. You don't need to include all 8 performance domains. That would be too much. That would take too much time. That would not be a reasonable thing to do. But are we including some of these performance domains in the narrative? Number 2 is the specificity of comments. So is there supporting evidence? Are there examples? If you have a narrative that just says the student has excellent clinical reasoning skills, they have excellent initiative, they have excellent professionalism, you're hitting a lot of those domains, but there's nothing specific there, right? There's no supporting evidence. There's no evidence that you know who the student is. So that's the second component. And 3 is the usefulness to the reader. So whoever's reading the narrative, will they get a good idea of who that medical student is or who that resident is? And so this is usefulness to the program director who's deciding whether to accept the student to residency, or this is for the reader itself, for the learner. If they read this, will they know what they should continue to do to excel, or should they get some constructive feedback about what they could do to improve? So here is the narrative evaluation quality instrument. It's broken down into 3 parts. So here's the performance domains, and depending on the number of performance domains, you get a score. There's specificity of comments. So are there pieces of supporting evidence? Are there specific examples given, right? A specific example might be that the student gave an excellent presentation on a patient who presented with possible autoimmune encephalitis. That shows that you're actually remembering that student and some specifics about that student. And then the usefulness to the trainee. So you can get a 4 on each part of this instrument. It's a total score of 12. And what they determined in the study is that a score greater than 7 is considered to be moderately useful. So those are the 3 frameworks. Not one framework isn't better than the other. I think it's just important that when we're writing narratives, we think about these frameworks and we think about one of them when constructing the narrative. And it might be that rhyme works really well for one student and doesn't work as well for the other, and then NEQI works better for that. Okay.
So we want to switch gears for a second, talk about a significant issue in narrative evaluations, which are biases that can disadvantage various groups. And these biases are usually not explicit, but implicit. An implicit bias is an unconscious collection of stereotypes and attitudes that we might develop towards certain groups of people. And in the literature, there's been a lot of studies examining the biases in student evaluations. And, wrong way. Thanks. The most significant biases affect women and underrepresented medical students. So, for example, different studies have found that women are more likely to be described using personal attributes. This bias leads to women being described with words such as lovely, sensitive, and enthusiastic, while men are more likely to be described as scientific and quick learners. This isn't to say that being described as lovely is always bad, but it's a personal attribute. And since we teach and assess students based on competencies, we should primarily use competency-based language to evaluate them. This is where I think it's helpful to go back to those things that we were talking about, which is this is what people are looking for, right? And so if what we're saying is that somebody is lovely, it really doesn't fulfill the question of, does anybody want them as a resident? Similarly to women, underrepresented medical students are more likely to be described using personal attributes like pleasant, as opposed to competency-based words such as knowledgeable. And then a study of 6,000 applicants to all the residency programs at Yale during the 14-15 season were analyzed, excuse me, and they found that compared to URMs, white students were actually more likely to be described using words that were considered these standout phrases such as exceptional, outstanding, and best. These are some examples of competency-based descriptors versus the personal attributes. And you can see that advanced, comprehensive, and efficient describe students' behaviors and competencies, while delightful, lovely, and nice are character traits. Oh my God, we have a flood. Okay, these are 2 figures from a study in 2019 that analyzed narrative evaluations. On the left, we see differences in word choice between URM and non-URM students. In purple are words more likely to be used in the descriptions of non-URM students, such as outstanding and excellent. And in green are words more likely to be used in URM students, such as pleasant and nice. Similarly, on the right is a distinction between men and women. So women were more likely to be described with these red words, warm and caring, whereas men were more likely to be described with these teal words, such as scientific. Great. Okay, so what are the elements of a high quality narrative? First, you should include specific examples of the student performance. Your comments should be based on direct observations, and adhering to one of these standard frameworks will result in more accurate, transparent, and less biased evaluations. Then there's practical considerations. First, the comments should be useful to the reader, and you should consider that whether the reader is the student, the clerkship director, a future prospective program director, or maybe somebody else. It's ideal to take notes in real time when you're working with the student. That's when the specifics and examples are fresh in your mind. And the narrative evaluation is going to be best if it's an active and intentional process. Then the process can't be overly burdensome. You should remember that the quality of your comments is more important than their quantity. Then this takes a lot of practice, but we promise that these skills will get easier over time. And lastly, a good narrative evaluation can later be the basis of a good letter of recommendation. And this is especially true if a student asks for a letter and it's been some time since you've worked with them and don't really remember anything. So we'd like to go through some real examples. And as Dr. Resnikoff can tell you, these are not uncommon. These actually aren't the students' real names, but they are real evaluations here on the first column. And so we'd like to give you some examples. So let's start with A. Joe is competent and performed as expected. So what do you guys think about A? It's okay? Does it fulfill any of the criteria? Do you feel that it would benefit from any additional information, Dr. Merlin? Right, we don't know. Joe could be barely passing or Joe could be a star. So we tried to modify them to give some more information, and we improved it like this. Joe demonstrated good history and physical exam skills. She was able to detect important physical findings such as a right pronator drift and mild spasticity in the right arm. So how is this better? Is it better? Sorry, I interrupted you. Okay, so we have some specifics. Great.
And I would actually add that Joe is competent and performed as expected also speaks to another problem with narrative evaluations, which is that there's certain code words, right? And program directors and certain people who are writing the evaluations might know what those code words are. So if a program director hears Joe is competent, they might view that as barely passed, like Dr. Merlin said, when that maybe wasn't the intention, right? So we should be trying to get away from these words and really giving specifics, giving objective evidence of what the student, how the student performed.
Okay, that brings us to B. Ben is a pleasure to work with. So probably we're a lot of us guilty of writing this at one time, but we promise we'll never write it again. And what additional information is necessary in order to make this useful? Yeah. Actually, I don't think so. I think that's a personal, interpretation, but you make a great point, which is this okay to wrap up the talk with, the evaluation with? That's different than that being the whole thing, right? So, no, I don't think so. Right, we all want people that are a pleasure to work with, but what else do we need to know?
But I think it's filler. I think.
But she's saying included with a whole bunch of other stuff.
Yeah, but I think explain why they're a pleasure to work with.
Right, so we tried to do that. Right, here we didn't, but we'd like to, yeah.
Sure, but I would avoid just saying that, because that's just filler. I don't think anyone will read that and make anything of it.
So we tried to elaborate by saying Ben has strong interpersonal and communication skills, develops good rapport. For example, he was able to gain the trust of a patient with severe anxiety. So now it's fleshed out and has more meaning. Okay, so next, Lee has excellent knowledge.
Good, bad,
Specific, non-specific?
non-specific.
It's a specific competency, but doesn't actually say anything, right? So we elaborated by saying Lee often contributed to rounds, sharing their excellent base of medical knowledge. For example, they shared a great deal about the causes of Parkinsonism and the diagnostic criteria for dementia with Lewy bodies. And lastly, Anne is well-mannered and polite. How about this? Right. Maybe you barely met her, maybe you didn't meet her, maybe she just squeaked by. What else? Anything else about this from the bias slides? Exactly. This is a classic gender bias. So we elaborated by saying the team appreciated Anne's professionalism. She's respectful to patients and colleagues, and several patients commented on her outstanding bedside manner. In addition, Anne shared with the team when she accidentally confused two patients' labs. So now it's about professionalism, which is important in all of the frameworks. It's specific. Examples are included, and it's way more useful. Okay. Now we're going to share some evaluations written based on these frameworks that we discussed. And this example was actually written by one of our faculty members at Downstate. And you'll see in a sec that it looks like it was written based on the ACGME competencies, which makes sense because, as Nuri was saying, our new innovations evaluations provide those prompts. So example 2. B is an outstanding student. He was thorough in his history taking and physical examination skills and was always looking for ways to improve patient care. He demonstrated confidence in his case presentations. He was always enthusiastic, showed interest, and asked great questions. He communicated well with patients and providers. He was very empathetic toward patients and their families and had great bedside manners. He came prepared to the floors and eager and motivated to learn. B has a good fund of knowledge and gave an informative presentation on myasthenia gravis. So you can see if you overlap the ACGME competencies, that the history taking and physical examination skills and looking for ways to improve patient care and case presentations are all elements of the patient care competency. This good fund of knowledge and informative presentation on myasthenia gravis is medical knowledge. Communication with patients and providers, empathy, and bedside manner are interpersonal and communication skills. So we didn't include all the competencies, but you can see this is a good example of a nice evaluation and included 4 of these ACGME competencies.
Okay, so let's move to another example. So T is an excellent student. Their write-ups were organized, thorough, and they have great presentation skills. They are a self-directed learner and extremely motivated. Their histories were accurate, precise, detailed, and well organized. Their physical exams were complete and age appropriate. Their oral presentation on ischemic stroke in the young was organized, comprehensive, clear, and succinct. Their knowledge base was well above average, and medical comprehension was excellent. They are bright, know when to ask for help, and show compassion for patients. All right, so when constructing this narrative, we use the narrative evaluation quality instrument. So we discuss T's overall performance in the beginning. We comment on their clinical skills, which can be seen in green. We note that their fund of knowledge was well above average, seen in pink. And we discuss their oral skills in orange, giving specifics about a presentation on ischemic stroke in the young. We comment on T's initiative in blue. And lastly, we discuss their professionalism at the end in aqua. So I think looking at this narrative overall, we have thorough descriptions of multiple performance domains, and I think it's useful to the reader. So it really fulfills all 3 components of the NEQI. All right, example number 4. Over the course of the rotation, Ed's histories became more and more complete, and by the end, they were often thorough and hypothesis-driven. He was helpful, especially when the floor was busy, and respectful to colleagues and patients. Ed was an active member of the team, from rounding on patients in the morning to collaborating with another student to educating a patient about her diagnosis of multiple sclerosis. He was a hard worker, has good manual dexterity, and was excited to learn. Okay, so here in this example, we include a below the line comment. So people who are preceptors are going to know about this in new innovations, right? And for those of us who are residents, those of us who are faculty members who write narrative evaluations and fill it out in the Qualtrics form, you're not going to see this. That's okay. This below the line comment is specific for preceptors. And what this below the line comment allows a preceptor to do is to note if there was a small instance or a recurring instance, right? So Ed was repeatedly 5 to 10 minutes late to rounds, despite clear feedback that rounds begin promptly at 8 a.m. So above the line is often going to be word for word in the MISPE, so it's quite important. Below the line does not appear the MISPE. So this is really just for the clerkship director, for the dean's office, and for the student to recognize that maybe this is something that they need to improve. And if it's a recurring problem, then it becomes an issue. Now, you can include something negative like this above the line. So, right, if it was egregious, if Ed was repeatedly 3 hours late to rounds, despite clear feedback that rounds begin promptly at 8 a.m., that should be above the line. That should be part of the narrative evaluation. But this is a little bit more subtle. Okay, so to construct this, we use the prime method, right? And you can see we discuss his abilities as a professional, a reporter, interpreter, and educator. All right, let's go back to the original example. So JJ was a pleasure to have on the team. She's a wonderful and caring person. She worked hard throughout the rotation and she will make a great doctor. So now we're all experts, right? Semi-experts. So we're going to make this a bit interactive and we're going to have you all create a narrative that's improved on this narrative, right? So for the people in the room, form groups of 3, and based on your group, you're going to use one of the 3 different frameworks. So group A, group B, and group C. So group A, write an evaluation using the ACGME competencies. Group B, write an evaluation using the PRIME framework. And group C, write an evaluation using the NEQI. For those on Zoom, Srinath is going to put you into breakout rooms. So let's do breakout rooms of 4, maybe. And so if you're breakout room 1, use the ACGME competencies. Group 2, use PRIME. Group 3, use the NEQI. And over here on this slide, I'll keep the slide open. So 10 or
33. So we'll do 8.
Yeah, that's fine.
7 because we'll be leaving one of them.
Sure. No, not 18. Yeah. Okay, perfect. Yeah, that works. Yeah. So what we're going to do is spend 5 minutes. So spend 5 minutes writing an evaluation on your own, and then spend 5 minutes sharing your evaluation with the people in your group. Okay. And then afterwards, I'm going to ask for volunteers to share your narratives based on the framework you're using. All right, so work on your own first.
Up to you. I was afraid the thing would stop working.
All right, if you're done writing your narrative, you can now share it with the people in your group or your breakout room, and we'll come back together in a few minutes.
Okay, we're gonna finish up in like a minute, so finish up your narrative if you don't mind, and
I'm going to close the breakout rooms
okay,
in
they're
60 seconds.
Are you unmuted? Join.
Yeah, I don't know.
Is that not joined the breakout or not? No, because then it would have said that.
Okay. All right, everyone. So welcome back from the breakout rooms. Hopefully there was some good discussion in the rooms. Does anyone want to volunteer? Who wrote a narrative based on the ACGME competencies?
Group A. Did anyone at Zoom do group A and wants to share with us?
Either on Zoom or in person. We'll accept any volunteers. Yes.
Are you group A? Come join us here so
Come
that
to the
the
front.
people can hear you.
All right, everyone welcome Dylan.
All right, so this is Group A, ACGME. So JJ has a breadth and depth of knowledge I've always seen from few medical students before. She is particularly interested in headaches and understands the means of differentiating subtypes and how diagnoses affect treatment modalities. Her bedside manner is respectable, and she's able to kindly and thoroughly explain to patients in the simplest of terms what is going on and allowing management to be a patient-shared decision-making process. She effectively is able to communicate with the attending and other residents any updates of what is going on. Rarely, she has difficulty listening to presentations in their entirety without losing focus. The more she continues to progress through her training, the more she has the ability to effectively close gaps in her knowledge and gain confidence in what she is doing.
Fabulous. That was so good.
That was really great, right? There were specifics. There were multiple ACGME competencies. There
Very
was
useful comments.
very useful. All right, Dylan, thank you.
Great examples.
Group B, who did prime?
Anyone want to mute themselves and share?
Anyone do prime in the room?
Okay, here we have group B over here. Oh, just one is fine.
All right. Robbie Sachs. Okay.
Okay, the prime evaluation. So JJ displayed thorough history and physical exam skills, often picking up on subtle details commonly missed. She was able to adequately show compassion to patients and their families, specifically standing out when she carried a patient with glioblastoma. JJ delivered focused and appropriate differential diagnoses on a consistent basis. JJ was excellent in counseling a patient with seizure.
Hey, thank you, Robbie. That was really excellent, right? So there was professionalism there. You could tell that the student was doing a great job reporting. There was managing, there was educating. That was great. Thank you, Robbie.
I think that is also a good example that the student doesn't have to be outstanding for the evaluation to be great, right? Like this may not be a superstar of a student, but it was still a very useful, wonderful evaluation.
Okay, NEQI, who wants to volunteer for the neurology based narrative? Dr. Merlin. No, you have to come up. Yeah.
All right, so JJ was a valued member of the team, following her patients closely and reporting daily changes in patient status and workup results. She demonstrated empathy at the bedside, spending significant time with each patient and their families. For example, she helped convince a patient of the importance of having a lumbar puncture. She arrived to work early and stayed late to assure all patients were cared for, and when a colleague was out sick, she took on extra responsibilities. She has demonstrated clinical competence beyond her level of training, eliciting accurate history and physical findings, and even making the challenging diagnosis of Guillain-Barré. She is ready to begin residency.
Thank you, Dr. Merlin. That was showing us how it's done. That was excellent. Okay. Thank you all for volunteering. So I think we can skip this since our examples are as good, if not better. So, to conclude, what are some next steps? And so the people at Rochester, the faculty members at Rochester who developed the NEQI, they actually had a follow-up paper that came out last year. It was published in Neurology Education, and it was really excellent. It was describing an initiative to really enhance narrative evaluations at Rochester among the faculty. And there were a number of measures that they took. So they established a yearly grand round on narrative evaluations. Don't worry, this doesn't need to be yearly, but we're doing the first step, right? We're having a grand rounds, we're educating. So that was one initiative they took. A second is that they provided feedback to faculty on their narrative evaluations utilizing the NEQI. So they actually formed a group, like a working group in the department, and they would have different faculty, and I think they had residents too, who would rotate in that group, and they would grade the narrative evaluations that faculty and residents write using the NEQI and scoring it. And so this had multiple purposes, right? One, the faculty would get feedback on their NEQI score and would learn ways to improve. And two, the added benefit was that the faculty members and residents who rotated on that working group, they were really immersed in this, right? So they really learned about how to write a good narrative evaluation. So it was kind of like a way to teach them by having them join the working group. And then another nice thing they did is they created an annual award for faculty and residents who write the most useful narrative evaluations. And the other thing I'll say is that I've actually been reading some of the mid-clerkship feedbacks that are written and grading those with the NEQI. And so something that I can do in a very respectful, constructive way is discuss some of those NEQI scores with residents, with faculty, and talk about how maybe the narratives can be even better.
So in summary, our suggestions are to be as specific as possible and use examples whenever possible. To use one of our frameworks, the ACGME competencies, PRIME, or the NEQI. Before you're even writing, we recommend to take notes about the student in real time, to avoid biases, and remember that narrative evaluations need not be exhaustive in order to be helpful. We have these references in case you're interested, and want to thank you so much for joining us today.
Thank you all. Does anyone have any questions?
Yes, Brian and Ziska. I'd just like to make a comment. I was looking at the Oxford University Guide for Evaluation of Medical Students, and there are two problems that certainly American medical schools seem to face, which British-style medical schools don't. And that is a formal evaluation like neurology boards used to do of a student taking a history, examining a patient, and making recommendations based on the history and examination. And this will take about an hour, and at least at downstate in Kings County, and I presume at Maimonides, where the students are divided into 4 groups. This would include 2 students at a time, and I would do it in 2 steps. I would do a formative evaluation, let's say before the end of the 2nd week, and a summative one later, which would be incorporated into the student's grade. After the formative, the attending or preceptor would be able to critically evaluate the student's performance and suggest improvements. It would take 2 hours out of the 4-week rotation.
Yeah, I mean, I think that's excellent that you do that. That's ideal, right? To spend 2 hours with a student and spend an hour formatively and then an hour summatively to help gather information to write the narrative evaluation. I don't know if that's doable, but I think that that's for everyone and for every academic institution or site. But I commend you. I think that's excellent.
It would only be 2 hours of a 4-week rotation, very specifically timed to an hour including feedback, which we used to, there wasn't a feedback in the old neurology boards, but you had an hour to take a history and have your exam observed, and then it'd be questioned for half an hour. So we could certainly fit this into an hour with 2 students, at least at the formative stage.
Yeah, it takes a lot of manpower, but it's yes, it's great.
I really don't think it does. I think 2 hours in 4 weeks, providing people do it consistently, one before the end of the second week and one before the end of the rotation. I do not think it will take much more time. Certainly could be included in the preceptor's evaluation of the student. And I think it's feasible, and lots of other medical schools in Scotland, England, Australia, South Africa do this routinely.
Dr. Francisca, is it 2 hours per student or 2 hours for all 8 students?
No, 2 hours for 2 students at a time. I think at least at downstate in Kings County, one never has more than the 8 students in each site. I presume Maimonides is the same. There's never more than 2 students at a time, and each site has a preceptor.
Yeah, no, it's something to consider. Thank you. All right, any other questions? Yeah, Serena. Yeah, so Srinath asked, what's the ideal length of an evaluation? What's too long? I don't think there's a right answer for that. Yeah.
I think that goes back to the question of quality being more important than quantity. So if you have a lot to write, then go ahead, write, a whole page, but that's unlikely to be the case, right? So more commonly, you have 2 competencies maybe that you want to cover. Maybe you have 1 or 2 examples in each one, and it ends up being like a nice little paragraph.
And as a resident, you're not writing the narrative evaluation that goes into the MISPE, but what you write certainly is going to be utilized by faculty members. And so I agree, quality over quantity. And remember, we want this to be not a burden. This needs to be something that is easy to do.
And also specific, I remember, and Dr. Resnikoff is going to remember this, that there was a faculty member a long time ago that had a very, very long, 600 words per student, but it was actually the same 600 words for every student. So it ended up being meaningless. So as long as it's about your student, short and sweet, I think is useful.
Good question. Any other questions? Okay. Thank you, everyone. Meeting.